Good evening. My name is Kimberly McNeil, and I am the Director of Screening at the Colorectal Cancer Alliance. I have the honor and pleasure of welcoming you all to our first of a four-part series in health equity called Breaking the Barriers. And this one really gives a lead into the definition and the passion behind health equity and what it is defined. Before we get started, I would like to introduce our moderator, who happens to be a friend of the Alliance, and she serves on our Health Equity Advisory Committee as a chair. And it is with great pleasure that I introduce to you Dr. Pascal White. Dr. Pascal White is an associate professor of medicine at the Econ School of Medicine at Mount Sinai, with dual appointments in the divisions of gastroenterology and liver diseases. She previously served as a director of gastroenterology clinic for 7 years, where she led clinical operations and advanced patient care. She currently serves as the inaugural director of Health Equity in Action for liver and digestive diseases, where she leads innovative efforts to expand access to care and address screening disparities. Dr. White is a co-founder of the Association of Black Gastroenterologists and Hepatologists, and a co-chair of the Health Equity Committee for the Colorectal Cancer Alliance. Please welcome Dr. White.
Thank you so much, Kim, for that fantastic and wonderful, warm introduction. And I want to thank the Colorectal Cancer Alliance for the invitation to moderate this evening and for the privilege of engaging in this most important topic. Tonight is one of 4 series of webinars that will touch upon critical topics of health equity as it relates to colorectal cancer space. And this discussion will set the foundation for the other 3 webinars, and we sincerely hope you will tune in for them as well. And now it's my distinct pleasure to introduce you to our 2 panelists this evening. Dr. Renee Williams is a professor of medicine in the Division of Gastroenterology at NYU Grossman School of Medicine. Within the Department of Medicine, she is the Associate Chair of Health Equity and the Director of the Saul Farber Program in Health Equity. Her interests include health disparities in colorectal cancer screening and medical education with a focus on simulation education. She is the co-chair of the New York City-wide Colorectal Cancer Coalition, or C5, Risk Assessment and Screening Committee, and she served on the Board of Trustees for the American College of Gastroenterology from 2018 to 2024. Dr. Williams is also a co-founder of the Association of Black Gastroenterologists and Hepatologists. Welcome, Dr. Williams.
Thank you. I'm very happy to be here.
Awesome. The next panelist is Dr. Karen Mancera Cuevas. She is the Senior Director of Health Equity at the National Health Council, where she collaborates with a variety of national patient advocacy organizations on health equity policy, research, and program priorities. She has a professional background, which includes previously working in leadership positions at academic centers, emphasizing clinical, public health, and community-based participatory research at the University of Illinois at Chicago and Northwestern University. Additionally, she has engaged with the public in statewide governmental public health efforts in Illinois. Her more than 25 years of professional experience also encompasses varied nonprofit and policy-level settings. Programs developed under her leadership address chronic and rare disease health disparities in diverse communities of color, specifically targeting women and children at the community level. Welcome, Dr. Mancera Cuevas.
Thank you so much for having me today.
Wow. So let's get a foundation for this webinar. I'm going to start with Dr. Williams, okay? Let's get a clear definition of what health equity is. And can you please define this and describe the work that you do at NYU?
So health equity, in simple terms, is the human right for everyone to achieve their best possible health. And something I like to say is equity and equality are 2 very different things, meaning every individual has a different barrier, and within the healthcare system, we should actually work to mitigate those barriers as necessary. So for a real world example, think about a food pantry. If a food pantry gives every family the exact same amount of food versus looking at the household number and giving food commensurate to that number, the equity piece is giving the food commensurate to that number, whereas the giving everyone the same amount of food is called equality, but that may not work for a family. What may work for a family of 5 may not work for a family of 8. Or think about going to a doctor's office where everyone gets charged the same amount to see the doctor. versus looking at your income and saying, let me charge you based on your income and doing a sliding scale. So that would be equity. So thinking about transportation barriers, language barriers, how do we mitigate those barriers to make sure the patient has their best achievable health? There are a lot of different schematics that you can see. So for example, one of the more popular ones is someone crossing the street. You may have someone with a cane, someone with a wheelchair, and someone who's able-bodied. And you may have a slant versus a step. The able-bodied person can go down the step, but someone who's in a wheelchair, that's going to be an issue. So equity is providing these resources. Within my role at NYU, there's a huge focus on health equity, and we look at our patient outcomes, specifically looking at readmission rates to the hospital, length of stay, and seeing, is there a difference between different groups of people? And if we see a difference, can we think about some way to make that better? So for example, something that they do here is they have a partnership with God's Love We Deliver, where they look for food insecurity. And if they find that a family is food insecure, they provide medically tailored meals. And what they have found is that providing that medically tailored meal for a month actually reduces the time the patient comes back to the hospital. So those are things that you think about health equity. What are the barriers or health-related social needs that our patients face, and how can we, as a society, I guess even as a physician or as a profession, mitigate those barriers?
Fantastic. Thank you so much for those clear examples. Definitely created a word picture there. Dr. Monserrat Cuevas, along the same lines, how does your current position at the National Health Council touch upon the issue of health equity?
So the National Health Council is an organization that's more than 100 years in existence, right? So a lot of our work is really centered around patients, the patient voice, patient engagement, policy, and advocacy. So with the work that I do, we have more than 200 organizations, and those organizations work at the national level, right? So our organizations are patient advocacy organizations, are business and industry organizations, but are also professional membership organizations within specialty therapeutic areas. So the interpretation of health equity, right? So a lot of my work in health equity, my role is an inaugural role. So I've been there approximately more than 2.5 years. I really wanted to get grounding from the organizations as what was their interpretation of health equity, right? Because you're essentially trying to interpret health equity within the lens of 200 different organizations. And in the case of National Health Council, we represent rare and chronic disease. So in those listening sessions, it was determined there was a lot of really important common themes. There's the themes of health literacy, but particularly access to care was critical and key for a lot of our organizations. So we had a lot of conversations about what does that mean for different organizations? How do they position themselves? So the work that I do, in essence, is to be able to coalesce a lot of that, So part of that is in the work that I do, I host lunch and learns. We have a lot of educational opportunities and resources. We have an affinity group. We have online platform for our health equity leaders. The health equity leaders that represent the member organizations that we work with have different types of roles too. So we have health equity leaders that are programmatic leaders that lead multi-city programs across several cities in a particular disease state. And we have health equity leaders that are policy people that go to the Hill and advocate on behalf of patients. So we really work hard to be able to engage those leaders accordingly with the services that the National Health Council can provide.
Wonderful. Sounds like fantastic the work that you're doing. So just trying to kind of marry the two issues of health equity as it relates to colorectal cancer. For those of us in the audience or others who may not know what colorectal cancer is, let's set the foundation for this as well. So Dr. Williams, can you explain to all of us what colorectal cancer is, the risk factors for the disease, common symptoms, and the options that we have for screening? Just kind of give a global view.
So thinking about colon cancer, the way I explain it to my patients, it's cancer of the large intestine. So we know we have the esophagus, the swallowing tube, the stomach, the small intestines, and the large intestines. So your colon is your large intestines, and this is cancer of the large intestines. When you think about risk factors, and just as a piece of a point, it is currently the 4th most commonly diagnosed cancer in the United States, and the 2nd most common cause of cancer death within the United States. And if you're thinking about risk factors specifically, certain things we see is increasing age. We find it increase in people of male sex. If you have a family history of colon cancer, that's highly important. So if your mother, father, sister, brother, specifically your first-degree relatives, that makes it increased risks. And there are certain genetic syndromes, one of the more common ones being Lynch syndrome, that can be linked to colon cancer. So those are what we call not modifiable risk factors, because you can't modify those certain things. And then we have non-modifiable, we have modifiable risk factors, so things such as physical inactivity, smoking, unhealthy habits, having a high BMI or obesity, intaking red meats have been linked to increased risk of colon cancer. So those are the risk factors and for this particular disease. If you're looking specifically at the symptoms, we think about things such as blood in the stool or rectal bleeding. If you're having abdominal pain, those are some of the top 2 symptoms that we see with colon cancer. If you're not moving your bowels, you're noticing that your belly's getting bigger and you're not moving your bowels. If you're losing weight unnaturally, meaning you're eating and you find that you're losing weight, you're very fatigued, you have low blood counts or low iron, those are certain things that you may see. And if those are happening or those symptoms are happening, it's very important that you have a conversation with your physician as soon as possible. In terms of options for screening, we have many different choices now. So normally there's invasive and non-invasive. So we think about a colonoscopy. What is that? We take a tube with a camera and a light, we go inside your rectum, and we take a look around your large intestines. And we do this because we want to find polyps. Polyps are growths in the colon. Think about like a big rock or a tree. These polyps are what turn into cancer over time. And normally they tend to be benign. So we take these out early and they don't turn into cancer. So that's a colonoscopy. It's invasive, it's a bit higher risk. However, if you have a good clean colonoscopy and you're not at increased risk, you're good for 10 years. The other options, which are just as good, is a stool-based test where we can check your stool for blood. You send a sample into the office and they check to see microscopic blood. And that's something else that can be used. And recently, in the last year, we now have an option for blood tests, and that can also be used. So there are different ways you can screen and you have choices. And I think the best way to consider what's best for you is to have a conversation with your physician. So again, invasive is a colonoscopy. You can do a stool-based test, and we have a few different choices, or you can do a blood test. So those are your options for screening for colon cancer.
Fantastic. Thank you so much for that. And the recent trend has been the rising rate of colorectal cancer in individuals under the age of 50. And we call this early onset colorectal cancer. And this has been a rise of 1% to 2% per year since the 1990s. And this was the change that was the motivation, right, to lower the screening age from 50 to 45. And previously, the medical community was recommending screening at 45 only for African Americans. That was an ACG, clinical guideline, right? And now it's at 45 for all. But yet many people don't know that screening starts at that age, especially for those who have no symptoms who are at average risk. But it starts earlier for those with a family history of colorectal cancer. And so Dr. Macera Cuevas, how do you think we can address the considerable gaps in understanding about colorectal cancer screening and prevention, especially in Black and Hispanic communities where awareness is significantly lower?
I think in terms of like addressing considerable gaps, I think we also need to think about like access to care and locality, right? So like the challenge is when we talk about Black and Brown communities, they look very different depending on locality. Yeah. I can say I spent a lot of my career in Chicago. Chicago looks different than LA. It looks different than New York. It looks different than Miami. And so a lot of like those like constructs in terms of what are the medical systems, what are the FQHCs, what is the access to care, and all of those things are so multi-layered that oftentimes I think the best approach is really doing more work with those entities within those localities, right? So a lot of the challenges with particularly my experiences primarily more with Latino communities is how do we go from that primary care setting to then eventually the scary specialty setting, right? People that they don't know, right? That they don't have a trusting relationship and that they need to then develop a relationship in order to then do the next step, which in the case and the conversation that we're talking about is colonoscopy. Mm-hmm. Right. So I think that it really is important for medical systems within these cities that have diverse communities to be able to do a lot of micro type of tailoring to be able to work with those respective communities, particularly since these communities are not necessarily monolithic, right? There's a lot of intricacies, but also like entities that then they can navigate them people through these systems, right? You know, that so then it's not so scary, right? To then essentially say, well, you're having a lot of the symptomatology. We're detecting this after you have that primary care visit. maybe it's time to go in between being the pre-contemplative to contemplative step to then going to that specialist and then seeing where then that's going to lead you to. And I think that that's really in and of itself is a challenge with a lot of these communities have. It's that beginning, right? Being able to have enough trust in the system, enough trust in the navigators, and trust in the process to be able to move along to then go the detection route. So I think that a lot of work when we're talking about Black and Brown communities, from my professional experience, we should really be emphasizing that quite a bit more before looking at the bigger picture, which clinically has a lot of significance. Yeah, we want to detect as many people, but we also want them from a behavioral standpoint to be able to engage in the behavior to move along the process.
Wow, that is so interesting. It seems like there's a multi-layered approach, right? There are multi-layers of this barrier. We have physical barriers to access to care, and then there's like the psychosocial barriers to access to care, and then that layers on with the medical trust in the community, building relationships with each other to go that extra route. Dr. Williams, can you also share any thoughts about how to address these gaps, either in understanding about screening or prevention in these communities?
I agree with a lot of what Dr. Mancera Cuevas mentioned. I think we have to really think about, how can we address these gaps, thinking about things like transportation. Recently, there was a study by one of our colleagues that looked at ride shares for colon cancer, and they found a positive correlation to screening. Thinking about providing culturally appropriate services and thinking about, different layers. If you're thinking about barriers, there are patient level layers, which includes patient education, community level layers, provider level layers, and policy level layers. And if you're thinking about patient education, what can we do to make sure the patient understands their risk factor, their individual risk factor for colon cancer, and the benefits of having a colonoscopy? Thinking about provider level resources, again, thinking about providing patient navigation. Because for example, if you're in a system and you send a stool-based test kit out, the patient gets it, and what happens afterwards? Someone needs to give them information about how to do that test and how to send the test back. What does it mean to have a positive test? So having patient navigation or community health workers, we know have been found to actually have a very positive impact in marginalized communities. So thinking about those different things that you can do as a health system that can help mitigate those barriers for your patients is highly important.
Thank you for sharing that with us. In terms of like the health system is one thing, and we know that our trainees are part of that health system, right? So it's important as we talk about health equity that we acknowledge the impact we have on the next generation of physicians and providers to be aware of these issues in hopes of addressing them. And so, Dr. Williams, back to you. How can we address training the next generation of gastroenterologists on health equity in colorectal cancer screening in these communities at higher risk for this disease? And I know you've had experience as a former program director, so I want to hear your thoughts on that.
Education. It's interesting. I think what's happened, since we know COVID happened, unfortunately, and COVID actually unearthed a lot of disparities or inequities across different groups, different marginalized groups. And what was a positive impact is that medical schools started incorporating health equity to their curriculum. Now, in that case, it was there before, but I felt like after COVID, there was this increased interest. And so now when I'm finding young physicians coming out of training, they already have this baseline knowledge. They're interested in learning about these health-related social needs. I'm not so much about the numbers, about what the disparities are, but what can we do as an intervention? I feel like right now we're focusing more on what the cause, what can we do to mitigate these barriers versus here are disparities. Alaskan Native American Indian men have the highest mortality and highest incidence. We've gone from here's the facts to what can we do to intervene? How can we get involved in policy? How can we get involved more in patient education? So I think the education piece is really important, and I'm finding that our younger physicians are highly interested in those interventions and those strategies.
Wonderful. And if you're just joining us, welcome. This is the Colorectal Cancer Alliance Health Equity webinar, Breaking Barriers, one of a series of webinars that will touch upon health equity as it relates to colorectal cancer. So now we have defined health equity. We know what colorectal cancer is, the symptoms, the screening options, and yet we know that people are not getting screened. There are certainly gaps in equitable access for screening programs, but there is also personal barriers patients have to getting screened. And I think we touched upon this a little bit. But Dr. Mancera Cuevas, in communities where fear or stigma, such as masculinity-related concerns or fatalistic attitudes hinders the screening, how can we reframe conversations to reduce these emotional barriers?
So I find the question interesting, right? Because, like, particularly when it comes to masculinity, the concept of machismo, that's very much a thread within Hispanic culture, is very important. But also, like, when we're talking about, like detection and a lot of things, particularly within men in Hispanic community, we're also talking about, the issue of mortality, right? And fatality, which is part of the challenge with taking the exam in and of itself, right? Because it is then the confrontation of having to deal with the reality. If you have symptoms, are you necessarily going to explore those symptoms culturally, or are you going to ignore them and in some cases maybe use more spiritual avenues, right? In some Latino communities, it's the concept of praying it, or maybe that somehow, some supernaturally, it will disappear. And so I think that it draws into issues of assimilation and acculturation too, right? Because what you're asking then is, for many of these patients, is to kind of transcend the framework of what are traditional Latin American values to then what is more of an American value set, right? Which is deal with the condition, go through the process, go through those movements, get treatment, etc. And so I think it is a juxtaposition, right, for particularly a lot of Latino men to be able to straddle both of those worlds, right, at the same time. So to a certain degree, it is the apprehension, right, which may be occurring within the gender. But I think that there's also a lot of cross-cultural themes that are also underpinning oftentimes those decision making, which can be reinforced by the family system, by social circles, by religious circles. And so really the process is really being able to work then with those, like individuals, particularly those that have demarcations and factors, to be able to work through and marry both concepts, right? You don't necessarily want to negate the role of culture, but also you want to emphasize the importance of prevention and early detection, right? So I think that it really is working. And I think oftentimes this is really the best opportunity of when you can have the males, right, particularly male patients that have had colorectal cancer, be mentors to other men, right, to say like, hey, and I know I've worked in a variety of different areas in medicine where we have actually been very successful with doing that, where oftentimes it is the Latino male who's been encountered with the condition that is then able to mentor then this individual through the process and make them feel more at ease that they are going to be okay, and that awareness is key and detection is key, particularly because we want these individuals to be around for their families, for their loved ones, and for their communities.
Excellent. We talk about the concept of having a trusted community space, but they're trusted community partners and they're just trusted people in the community who've been through, these procedures, and they can speak on it on a personal level. And if someone trusts in what they're saying, they're more likely to actually do it themselves. Dr. Williams, have you seen this play out among your patient population? And particularly, what strategies are most effective in dispelling myths and misconceptions about colonoscopy?
I think it's a conversation. It's interesting because some patients will come and they'll be like, I heard that prep is terrible. So, I validate that feeling. I say, you know what? I had my first colonoscopy and you're right, it is terrible. But I think it's important to understand why you're having this test done. It's harder to deal with colon cancer. I think just taking the time to sit and just have that conversation with your patient makes a huge difference. And then acknowledging their feelings, acknowledging that, you know what, you're right. I understand where you're coming from. I understand your fears. And I think those things make a huge, huge difference.
Excellent. Dr. Macera Cuevas, any other strategies you would add?
I oftentimes, advise people, oftentimes there's so much misinformation online. I think that really is the primary source of the challenge, right? And particularly for a lot of clinical providers, because they see a lot of these worst case scenarios of like colonoscopy, and it really deters people from doing it. But I tell them, I said, this is not a reliable source that you're obtaining this information. And, the benefits far outweigh, right, significantly than the risks. And you really need to really look at the source of where you're getting this information. And I think that that's, like the big challenge that a lot of providers have today. Like they're going, this Google MD concept that, individuals who are not properly trained can just self-diagnose is a challenge, because then they go through all these assumptions and all these scenarios that are not very realistic. And really the conversation then with a lot of these patients is to ground them on actual facts and true information about what's actually going to be happening and what are, like those risks going into procedures. So I think actually sometimes reframing the conversation is the most foundational to all of this part.
Excellent. Thank you both for sharing these strategies. And I think I just want to kind of refocus on the community organizations as well, Dr. Mancera Cuevas. What role do community-based organizations play in bridging these gaps from awareness to screening to treatment? Like, how should we support and invest in them?
So community-based organizations play like a multifaceted role. So there's already been the conversation of the community health brokers, which in Latino communities is promotores de salud. And I've engaged with promotores de salud since when I was, very early in my career. But I think also too, it's just having those one-on-one conversations with community, right? So I've gone in, had conversations with community members, sometimes individuals who are afflicted with conditions, have worked in order to empower these individuals at the community level to essentially be ambassadors, right, in their community and work with community-based systems to then educate others about what was the reality of the test? And then if they're diagnosed with a condition, what actually was their lived experience, right? Because we talk a lot about lived patient experience, but oftentimes like the most illustrative lived patient experience you hear at the community level, because you can hear them outside of all of the traditional based systems, and you can really hear their voices and hear like what was their experience. And I think that really is like very powerful, right? So I think, engaging with communities, and I also say too, like when you engage with communities, these also have to be fair and equitable relationships. We can't necessarily expect us to engage in the community is waiting for us, and that they're just going to be like, let's do this. A lot of this is like years in the making in order to get communities to be invested, in order for them to have prioritization or attention. And as I always say, it's important too that when you're going into communities that also, particularly if they're community-based participatory research, to really have then monetary compensation for those individuals if you want to really be able to lift these types of initiatives, because otherwise there's not significant investment for those individuals who have sometimes other commitments, right? They may have their own jobs, they may have caregiving responsibilities, and all of these other nuances. So communities can be very intricate in terms of what it is that they need as well in order to succeed and be partners in a lot of these different health-related initiatives.
Well, thank you for that. And in just going into like the community-based organizations, I think Colorectal Cancer Alliance is the perfect example of an organization that is addressing gaps in colorectal cancer continuum, from awareness campaigns to supporting patients that are undergoing treatment. And some of these treatments include clinical trials, and representation definitely matters. So Dr. Williams, what barriers do you think prevent underrepresented groups such as Black, Latinx, Indigenous individuals from participating in clinical trials, and how can these barriers be reduced?
Thank you, Dr. White. I think that was a very important question. And I think we've talked about access earlier on in this program, and think about the access to study sites, think about transportation, time constraints, think about financial restrictability. If someone has to go to work and they don't get paid if they don't work, then that's a problem. I work in a safety net hospital, and sometimes even for patients coming in for colonoscopies, they're like, Dr. Williams, if I don't go to work, I don't get paid. So those are all the different things. And I think about the historical mistreatment of certain groups, of marginalized groups, lack of diversity within the study team. So all those different things I think make a huge difference. And in order for us to really make a difference, we have to go out. I think you mentioned community health workers. I think community-based participatory research makes a difference. And what that means is I, as a physician, we're not coming to the community and saying, here's what we're going to study. we have a meeting with community leaders and we say, here's what we would like to study. What do you think are ways that we can do this in a very effective manner where both of us are benefiting? So you now start So what you're starting to do now is you're starting to involve the community in those research ideas. You make sure you diversify your research team. Make sure your research team can go to different communities. Make sure they're bilingual or trilingual, and just make a concerted strategic effort to reach out to groups to get a better representation within your clinical trial. So I think that's a really important aspect of it. And just think about from the patient's perspective, there's a lot of mistrust. When I tried to recruit in my own hospital system, a lot of patients also didn't understand. They're like, what's a biopsy? What are you going to do? What are you going to do with my information? There's concerns about privacy. So again, education, education, education. Educating the patients around what you're doing, educating that it's important that they're involved in the study, because you can say, listen, if this treatment works, we know it works in your specific group. So all those different things. And I think specifically community-based interventions are really important, and community-based participatory research, again, involving them in the planning, design, and structure of your trials makes a huge difference. And reaching out, and also on the team itself, as I mentioned earlier, make sure they have cultural humility, not cultural competency, but be culturally humble, and then have those communications with those different communities, be culturally tailored. I think those are different things. And also being very open and honest about the mistrust and distrust in different communities, saying, listen, we acknowledge the history, we acknowledge it happened, but we're trying to be better, and we're trying to do better.
Excellent. In order to break down barriers, sometimes you got to bridge the gap, right? And so, Dr. Macera Cuevas, any additional thoughts?
So my additional thoughts, I've done clinical trials for many, many years. And part of the challenge, when we talk about clinical trials, particularly in diverse communities, is really expecting that the patient is going to take a leap of faith outside of standard treatment, right? And really having conversations based on that. And I can say I agree wholeheartedly with Dr. Williams. There's a lot of these considerations to take in mind, but sometimes I've often had patients that are just too scared. They're just too scared to do a clinical trial, even if they're they may have advanced forms of disease. And so oftentimes, with the approach also too is making sure that there's comfort and reassurance that this is something, and particularly when you're working right with those providers that are engaging individuals in clinical trials, particularly specialty areas, not just everybody is going into them, right? The clinician is oftentimes very detail oriented in terms of really considering their clinical history. But really having these grounded conversations with individuals is really important so that they get to the comfort level that this is maybe something that they want to take that leap of faith. And I oftentimes tell people, being in a clinical trial is a leap of faith, it's entirely on them, right? For them to engage in this type of research. And oftentimes for me, I considered it more of a privilege and opportunity to work with the individuals so that they offered the space and opportunity for me to be able to engage with them. Not necessarily that I was pushing on the product of research, but I think it's important really to ground the conversation in that the fact that the patient is going to be really, they have a locus of control where they're assuming that they're going to take on what may be a challenge and an unknown, right? Particularly if they've been under treatment for several years. So I would really want to include in the conversation that type of consideration.
Thank you for that. And just in general, your sincerity and your humility in approaching the population that way, they can feel that, right? And that's the way, again, to bridge this gap and to allow them to understand that this is something that they could potentially trust and take a leap into those clinical trials. I just want to remind the audience to, did you have a question?
I was going to add,
Go.
I guess.
Go, yes, please.
All right, so I was going to add to what Dr. Macera Cuevas mentioned. I think patients may think you're experimenting on it. And I think to your point is that grounded conversation, because I've had patients like, why are you experimenting on me? And you're experimenting on me because I represent a certain group. And actually addressing all those fears and concerns is really, really, truly important.
Excellent. Thank you so much for bringing that out. I totally agree. I just wanted to remind the audience to place any questions they have in the Q&A box, specifically as we make our way to that portion of the program shortly. Dr. Williams, going to ask you if there is one piece of advice about what we can do to increase awareness about health equity in the CRC space, what would it be?
Awareness for patients or for providers?
Or both.
It's interesting. I think patient education, I've said that many times. I think the patient education piece is really huge. The New York City C5 did a huge campaign years ago, really centered on education, and they saw a difference in the outcomes, but also just offering support and resources, offering navigation, offering coverage for colonoscopies. I think those are important. From a provider perspective, I think I'm going to say education again. I mean, and when I say education, it's not just book knowledge, but understanding where these inequities come from. What are the roots of those inequities? Meaning, let's look historically at what's happened to marginalized groups and how is that actually, what's the downstream effect that we're seeing today? And I found that when I've had those conversations and I kind of go back in history, our past informs our present. When people truly understand those concepts, it makes a difference in terms of how invested they become. So I think from our perspective, understanding resources that are available, what's within your system, what are your options as a provider? Because, as we're GI doctors, we're not doing the screening conversation, right? It's going to be our primary care counterparts, or even OB-GYNs do screening. What's available within your system? What are the different screening options? And separate from that, like, where do these disparities come from? Why should you care? Like the why. There's a book called, Start with the Why. Like, why is this important? Why are you seeing these disparities? So I really like to think everything should be grounded in education, not just education about the disease, but about the resources and the gaps that exist.
Excellent. Dr. Masada Cueva, same question.
For me, I think that it's important, like I agree with everything like Dr. Williams has said. When I speak with patients, when I talk to them, I really like having grounded conversations about, like, you're hearing about colorectal cancer, you're hearing about breast cancer screening. Like, sometimes they're like, where do I start? Like, what is more important? I really think that it is important for them to work with providers, right? To be able to really set a priority. So like when they're doing the screenings for these different types of conditions or diseases, they really need to work with then someone who understands their medical history, then to be able to guide them. Because oftentimes, like, the health equity challenge is that oftentimes patients just don't know, like, what is the priority? Like, what is the next step? Like, should I be thinking about blood pressure? Should I be thinking about cardiovascular disease? There's 10 other cancers I should be thinking about. And it's not trivial. I think that really simplifying the process, and I oftentimes think of as a health educator, how can I make things simpler so that patients then know the easiest way to make decisions, so that it doesn't seem like this is something that's going to overburden them or overwhelm them, right? So I think that it's really important to them be able to center the patient so that they have decision making, which is much more simpler than sometimes they may be receiving the information. Like, this is too overwhelming. If you're talking to me about having colorectal cancer screening, and then I'm going to be sedated, and then I'm going to be in the hospital, and then I'm going to be doing all these other things, instead, to really piecemeal, right, to compartmentalize the decision making so it looks like it's something that's much more manageable, and also ways then that then they can then tap into the navigator, tap into the translator, understand access, because access also has to do with coverage, right? Because a lot of patients will say, I don't know if I have the money, I don't know if I have insurance, I don't know if I can do all these, so that then there's then ways to then make sure that then that individual then takes the decision to do that specific behavior, and then goes on, right, to any of the other conditions that they also need to resolve as well. But I think it's particularly important for patients to be able to have a prioritization system that they're working with providers so that they clearly know what then are the expectations of the next steps and the timeline as well.
Excellent. Thank you both for those strategies. We know that colorectal cancer is common, is preventable with screening, and addressing equity challenges in the space is worthwhile because we know that colorectal cancer has a higher survival rate if caught at the earliest stages, right? So we like to emphasize that prevention, whatever screening test that you choose, the best test is the one that gets done. And bottom line, all people need to be screened for this disease, and because it definitely does save lives. And you should get screening at 45 years old if you're at average risk. So this is the portion of our program where we want to bring the audience into the conversation. Please place your questions in the Q&A box for Dr. Williams and Dr. Maceda Cuevas. We'll try to answer as many as possible. I have one here for Dr. Williams. What recommendations do you have for people who have been recently diagnosed with colorectal cancer?
Thank you. I think one of the first things I'm going to say, and this is a gastroenterologist as me, is share that with your family because a family history is really important. If you have siblings, if you have children, it's like highly important that they know because they are at increased risk, and the age of your diagnosis is very important. So I think share sometimes in certain communities we don't share our health history. It's extremely important. Engage with your provider, ask questions, be an active participant in your care. But the one thing I would say honestly is just make sure your family knows that you have this diagnosis, and specifically first degree relatives, because then they themselves need to get covered and get screened.
Excellent. Thank you so much for that reminder, because again, we say 45, 45, 45, but if you have a family history, you can start as early as 40 or even earlier, depending on when that family member was diagnosed in your family. So that's extremely important. Dr. Mancera Cuevas, question for you. What are some strategies for community programs who aim to increase their screening rates?
Oftentimes what I tell community programs is please engage with a provider so that you're not just working with like a primary care provider, but you're also working with a specialty provider, because it really is key in terms of engagement. Because oftentimes with community-based programs, they may be stuck in that more of that provider that's the primary, but it really is a specialist that really can then provide then more of that screening, detection, et cetera, particularly in gastroenterology that is highly specialized. So oftentimes when there is particular types of diagnoses or conditions, it's really important to have that set up at the onset, right? So that that person is automatically navigated through the system.
Thank you so much. Question for both of you. What would you tell the person with symptoms who says to themselves, I'll deal with this later, maybe in a year or two? What is your advice to them? Dr. Mancera Cuevas, I'll start with you.
Well, what I would say is that it is important to really, prevention is key, right? And so, oftentimes with community members, I say, we want you here for the long run, right? So like if there's something in your body, anything that's unusual, it's important to see a doctor as soon as possible to be able to rule out anything that may be unusual, or if you need to have any type of treatment, right? But it's better to know that from the onset than making sure that you take care of your health instead of preventing, what could be the potential inevitable, which is not really doing early onset screening. So that's really what we want to avoid. So I really try to spin it in a way in which community members are empowered, are engaged, and are able to take to the lead of decision making early on.
Thank you so much. Dr. Williams, I'll give it the last word.
And I think also, really emphasizing we understand, where you're coming from, but that the earlier we figure out what this is, the better it is. Specifically with this kind of cancer, the earlier stage you are, the better your survival. I mean, clearly the conversation would have to be geared towards the patient I'm speaking with, but just really emphasize it's really important, not just for you, but for your loved ones and your family member and your community, that we don't wait on these things because it can make a huge difference in the outcome.
Thank you. Thank you. Thank you to our fantastic panelists for a fantastic discussion on health equity in the colorectal cancer space. And to each and every one of you, our audience, for joining us this evening. I will now pass it back to Kim to close out the webinar.
I would like to take this time to extend my sincerest gratitude to all of our sponsors, our core sponsor, Olympus and Merck and Bristol Myers Squibb, and the wonderful panelists for taking time to engage in this meaningful conversation. I will leave you all with this quote as a final thought. Health equity, in the words of physician and epidemiologist Kamara Jones, says that assurance of the conditions for optimal health for all people. Achieving health equity requires valuing all individuals and populations equally, recognizing and rectifying historical injustice, and providing resources according to their needs. Thank you.